Hi, this is Dr. Jade Park with Sclerotherapy Training Online. This is the Sclerotherapy Instruction Manual for medical professionals. We're going to talk about science, techniques, patient care results. This is an updated manual to the original manual that was produced. So let's get started. What is sclerotherapy? Sclerotherapy is a minimally invasive procedure to treat varicose veins and spider veins. It involves injecting sclerosing agents into the affected veins, causing them to collapse and get reabsorbed by the body. Sclerotherapy improves the cosmetic appearance of the legs and alleviates symptoms associated with venous insufficiency, such as pain, swelling, cramping, and unsightly veins. Here's the history of sclerotherapy. Sclerotherapy has been around for centuries, but it didn't always look like what we do today. Back in the 1600s, we had a Swedish physician named Zollicoffer who was literally injecting acid solution into veins to try to shut them down. Obviously, we've come a long way since then, but this was the first idea of what we now call sclerotherapy. Then in the 1930s, this is when things started moving forward with the introduction of sodium moreuate as a sclerosant. It wasn't perfect. It had some pretty severe side effects, but it laid the groundwork for what we're doing today. In the 1940s, we got sodium tetradecyl sulfate, which was a huge improvement, less painful, more effective, and it paved the way for modern sclerotherapy techniques. Polydocanol followed in the 1960s, and it's been a gold standard ever since. It wasn't a one-time breakthrough, but it's been a continual process of refinement. Why does this matter? Well, the evolution shows us that sclerotherapy is backed by hundreds of years of development. We've tested, studied, and perfected this technique for over centuries. That's why it's so effective today. Scientific principles and mechanism of action. Your veins are part of the venous system responsible for getting deoxygenated blood back to the heart. This includes superficial veins. These are the veins you'll primarily be dealing with in sclerotherapy. They're close to the skin and more prone to develop varicose veins or spider veins because they don't have much muscular support. Deep veins. These are within the muscle tissue and are responsible for carrying most of the blood back to the heart. These aren't our target in sclerotherapy, but they play an important role in overall vein health. Perforator veins. These veins connect the superficial and deep systems. When they malfunction, they allow blood to flow backwards into the superficial veins, contributing to varicosities. What happens when veins fail? They become dilated and visible, leading to what we call varicose veins and spider veins. Blood can pool in these areas, causing discomfort, pain, swelling, and cramping. It's not just a cosmetic issue, it's a health concern too. Mechanism of sclerotherapy. So what happens inside the body during sclerotherapy? Here's a step-by-step. Injection. You're using a fine needle to inject a sclerosant directly into the affected vein. Precise technique matters here. Endothelial damage. The sclerosant immediately damages the endothelial cells lining the vein. Think of this as creating controlled damage. It's exactly what we want to do to collapse the vein. Thrombus formation. The body reacts to this damage by forming a clot within the vein. Fibrosis. Over time, this clot is replaced by fibrous tissue, sealing off the vein permanently. Resorption. The body then reabsorbs the fibrous vein and the blood is rerouted to a healthier vein. This is where different sclerosants come into play. They each work a little differently, but follow the basic endothelial damage fibrosis resorption pathway. The choice of sclerosant will depend on the size of the vein, the location, and the patient's history. While many types of sclerosing agents are available, For this course, we're going to concentrate on three main sclerosing agents. First is hypertonic saline. This is your basic choice. It works by dehydrating the endothelial cells in the veins, causing the cells to die and the veins collapse. Now, it's cheap and it's readily available, but it comes with some downsides. It burns, and your patients will tell you this. And also, you have to watch out for ulcerations and hyperpigmentation. Polydocanol, or a sclera as it is called, is your luxury vehicle of sclerosants. It's less painful for patients, super effective, and has an excellent safety profile. The downside is that it's more expensive than hypertonic saline, but the cost-benefit ratio is well worth it, especially when patients are highly sensitive and worried about pain. Sodium tetradecyl sulfate, or sotraticol, is a powerful sclerosant used for large veins. It is highly effective, but you have to be cautious with some patients because of potential allergic reactions and skin discoloration. It was once FDA approved in the US, but has since lost FDA approval. So this is something you have to keep in mind when considering it for your treatment plan. It should be noted that this drug was not withdrawn for concerns about efficacy or safety. Effects on spider veins and vascular lesion. Let's look at the effects of sclerotherapy. Reduction of visible veins. After sclerotherapy, veins start fading. Some disappear almost instantly, while others take few weeks or even over several treatments. This is a huge win for both cosmetic reasons and for symptom relief, such as pain, swelling, and cramping. Why? Because blood is no longer pulling in these problematic veins. Improved aesthetic appearance. Patients don't just feel better, they look better. And that does wonder for their self-confidence. Cosmetic improvements are huge motivators for patients seeking sclerotherapy. Symptom relief. Many people assume sclerotherapy is only cosmetic, but the relief from pain, swelling, and heaviness in the legs is a major benefit. It's important to educate your patients about this because they don't often realize that these symptoms are linked to venous issues. Clinical studies back this up, showing high success rates when treating spider veins with sclerotherapy. But here's the thing, success depends on technique, the right sclerosant, and understanding which veins can be treated with sclerotherapy versus those that need something more invasive. Indications for sclerotherapy. Spider veins, or telangiectasias. These are thin, web-like veins near the surface of the skin, typically on the legs. These patients usually come in for cosmetic reasons, and sclerotherapy is incredibly effective for them. Reticular veins. These veins are larger than spider veins, typically blue in color, and they often feed into spider veins. Treating reticular veins can sometimes improve the appearance of spider veins. Varicose veins. For smaller varicose veins, sclerotherapy can be a great option. If the veins are larger or symptomatic, we might need to combine treatments. But for medium to small size varicose veins, sclerotherapy can be effective. Here's a side note. Ultrasound is often required for insurance coverage, especially for varicose vein. That's something you have to keep in mind when navigating treatments for patients concerned about cost. Contraindication for sclerotherapy. There are several situations where you absolutely should perform sclerotherapy. The first is allergy to sclerosant. If a patient has a known allergy to the sclerosing agents, then you don't want to deal with the potential side effects of anaphylactic reactions. Acute thromboembolic disease. Conditions like DVT or pulmonary embolism are contraindications. You don't want to risk further clotting issues. Severe systemic diseases. If the patient has severe cardiovascular or respiratory conditions, This isn't a treatment you want to take lightly. These patients might not respond well to sclerotherapy due to increased risk. Pregnancy and lactation. There's not enough evidence about how sclerotherapy affects pregnant or breastfeeding women, so it's better to avoid it. Infection at the site. If there's any infection on the skin where you'd inject, you could exacerbate the condition. Always wait until infections are fully healed before performing sclerotherapy. Hypercoagulable states. Patients with conditions that make them prone to clotting need careful assessment, and sclerotherapy might not be the best option. These patients need thorough evaluations, and you may need to involve a hematologist in the decision. Immobility. If a patient is immobile or has limited mobility, there's a greater risk of complication like DVT. Walking after treatment is crucial, so immobility increases risk. Precautions and consideration. Not all patients are alike. You'll often be in the gray area with patients who have multiple issues going on. These precautions are here to help guide your judgment. For larger babies, sclerotherapy is typically ineffective, so make sure that you tailor the sclerosing concentration and volume appropriately and select the right patient. Compression therapy. After sclerotherapy, patient needs to wear compression stockings to reduce the risk of complication like hyperpigmentation and thrombophlebitis. Don't skimp on this advice. Explain why it's essential to the recovery process. Allergic reactions. Although rare allergic reactions can happen, it's vital to monitor the patients for signs of hypersensitivity during and after the procedure. This is where your attention to detail really counts. Pain management. Sclerotherapy isn't pain-free, but it's manageable. Some discomfort is normal, and discussing pain management option beforehand, like topical anesthetics or over-the-counter pain reliever, can make the difference for patient comfort. Pre-treatment guidelines. Patients should avoid anti-inflammatory drugs, aspirin, or blood thinners for 48 hours before treatment, unless otherwise directed by a physician. You don't want to increase the risk of bruising or bleeding at the injection site. When it comes to patient selection, you have to be thorough. Not every patient is a great candidate for sclerotherapy, and it's up to you to make the decision. Here's your checklist. Clinical assessment. What is the extent of the venous disease? What is the patient's medical history? Are there any underlying conditions you need to consider? Vein characteristics. The size and location of the veins matter. Some veins are ideal for sclerotherapy, while others might require different treatment like endovenous laser therapy or vein stripping. Patient expectations. This is critical. You need to set realistic expectations. Some patients will expect a one-time fix, but it's your job to educate them. Explain that multiple sessions might be necessary and that side effects like temporary bruising can happen. Compliance with post-treatment care. If a patient can't commit to the aftercare like wearing compression stockings or following up for additional treatments, that's a red flag. Post-treatment care is essential for success. And if the patient isn't willing to follow through, it can impact their results. Patient consultation and informed consent. You can't just jump into sclerotherapy. You need to really know your patients. This is a crucial step. What are you looking for? Medical history, current medications, allergies, and most importantly, what do they expect from this treatment? For medical history, you need to ask everything about their past treatments to current medications, is the patient diabetic, clotting disorders, cardiovascular problems. Don't skip this step. Any of this could affect the outcome. Patient expectations. This is the part that can make or break the patient's experience. You need to set the record straight about what sclerotherapy can and cannot do. Don't oversell it. If they're expecting a one-session miracle, that's not going to typically happen. Sclerotherapy often requires multiple treatments. and the cosmetic improvements will come in phases. Informed consent. Informed consent is more than just a form, it's a conversation. Talk to them about the procedure, the risks, such as bruising, pain, hyperpigmentations, and more, and the aftercare. When they sign that consent form, make sure they're fully on board and understand everything they're getting into. Vein assessment. Let's get down to it. How do you assess the veins? Visual inspection. First, your eyeball is the obvious. Looking for veins that are visible, such as spider veins, reticular veins, varicose veins. You're mapping out your game plan by looking at it. Palpation. You're not just looking at the veins, you're feeling them. Are they firm, soft? How do the surrounding tissues feel? And duplex ultrasound is an option for patients with large varicose veins and a history of venous insufficiency. This is the gold standard. You'll get real-time imaging of how the blood flows or not flowing and whether or not there's reflux. And you want to document everything. Trust me, this documentation will be your baseline when you start seeing them for follow-ups. Pre-treatment guidelines. Once you've done the consultation, they sign the consent form, let's prep the patient. Medication adjustments such as anti-inflammatory drugs like ibuprofen or aspirin must be stopped at least 48 hours before the procedure. The idea is to reduce the risk of bleeding and bruising. Make sure you tell them to check in with their primary physician before stopping any important medication. Skin preparation. No lotions, no oils, no shaving the leg on the day of the treatment. Keep the area clean. Clothing and compression. Tell them to come in wearing loose clothing and bring their compression stockings. You're going to need those right after the treatment. Required equipment and materials. You're going to need sterile gloves, alcohol swabs, fine needles, compression stocking, of course, the sclerosant. Duplex ultrasound machine. This is a must if you're dealing with larger varicose veins. Also, typically, insurance will require this. This allows you to map out exactly what you're working on. Make sure your procedure room is sterile and organized, and efficiency is a key to a smooth procedure. Now, sclerotherapy techniques. This is where you need to be precise, calm, and focused. Injection techniques. Preparation. First, get the patient in a comfortable position. You want full access to the treatment area, clean it thoroughly with antiseptics, and load your syringe with the appropriate concentration of the sclerosant. Intravenous injection. The needle goes up, bevel up at a shallow angle. Always aspirate to confirm venous access before injecting, then inject slowly. Compression. Right after the injection, apply gentle pressure to prevent any leakage, and then put those compression stockings on when you're complete. Choosing the appropriate concentration. The concentration of your sclerosant depends on the size of the vein that you're dealing with. Hypertonic saline. For larger veins, you're using 23.4%. For smaller spider veins, you may dilute it with 50% saline and 50%, 23.4% hypertonic saline to give a half dose volume. For sclera, typically for spider veins, you're sticking with a 0.5% dilution. And for reticular veins or larger, you'll need 1%. For citraticol, although this isn't FDA approved, but some practitioners still use it for reticular veins, typically at 0.25 to 0.4%. You want to be cautious with larger veins because the risk of complications goes up with this drug. Procedure protocols. Sterilization and safety standards. Sterilization and safety are non-negotiable. Sterilize everything, your instruments, needles, gauze. Make sure you're using single-use needles to avoid cross-contamination. Don't skip on PPE like sterile gloves. You need to wear a mask and eyewear. Make sure your disposal of sharps follows proper protocol as well. Pre-procedure pain management could be involved applying lidocaine cream about 30 minutes before the procedure. During the procedure, fine needles, slow injection can help minimize the discomfort. Afterwards, you can recommend acetaminophen or ibuprofen to manage any post-pain. Tell the patients to elevate the treated area to reduce swelling and discomfort as well. Handling sensitive skin areas. You've got to be extra careful with sensitive areas like the ankle or around the knees where the skin is thinner. Use lower concentrations of sclerosant and avoid injecting too much solution in one spot. You can also apply cold compress to these sensitive areas. Make sure you monitor closely for adverse reactions such as excessive redness, swelling, or pain. For home care instructions, post-treatment care is everything. Post-procedure care and patient instructions. For immediate post-procedure care, you want to start with compression therapy. They need to keep those compression stockings on for 24 to 48 hours continuously, then only during the day for the next 2 to 3 weeks. Ambulation. Get them walking for 10 to 15 minutes immediately after the treatment to prevent DVT when it comes to avoiding complications. Patients need to avoid hot baths, saunas, and sun exposure for at least 48 to 72 hours. If there's discomfort, acetaminophen is fine, but NSAID and ibuprofen can cause bruising, so they should be careful in choosing NSAIDs over acetaminophen. Managing side effects and complications. Bruising, swelling, and redness are totally normal, but patients should report any if this lasts for more than a few days. Hyperpigmentation, such as temporary darkening along the treated veins, can happen, but it usually fades over time. If the patient develops superficial thrombophlebitis, use a warm compress and anti-inflammatories for inflammation along the vein. If it gets worse, they need to come back in to see you. For follow-up, the first visit should follow up within about 1 to 2 weeks post-procedure. Subsequently, every 4 to 6 weeks to check on the progress and to determine if more sessions are needed. Combination therapies and advanced techniques. One of the most powerful things about sclerotherapy is its ability to work alongside other treatments. Think of it like this. Veins don't stand a chance when you're hitting them from all angles, and you got to tailor the combination to individual patients. So here are the options. Laser therapy uses focused light to heat and destroy veins. Sclerotherapy, on the other hand, chemically collapses them. Together, it's like a 1-2 punch. Let's say that the veins are stubborn and are not fully responding to sclerotherapy. A laser can step in and finish the job, targeting residual veins that need extra attention for complete closure. Study shows that improvements are shown when they're combined with laser therapy with sclerotherapy. But this combo works best for small to medium veins. For some patients, though, sclerotherapy alone can get the job done. So it's the decision to use combination is dependent on the patient and you, and about the specific veins and the patient's overall health. Radiofrequency ablation uses radiofrequency energy to close off veins. Think of it like microwaving those veins shut. RFA usually is your first move for larger veins. Once that's done, sclerotherapy can clean up the smaller superficial veins. This combo covers both deep superficial venous insufficiency, giving you a complete approach to a patient's venous issues. The results can be impressive, especially in more complex cases. Ambulatory phlebectomy is where you're physically removing large veins through a small incision. Once the big veins are out, sclerotherapy steps in to treat the smaller spider veins and reticular veins behind. This is great for patients with extensive varicose veins. You're giving them immediate results with phlebectomy and finishing them off with chemical ablation of the smaller veins. Foam sclerotherapy involves mixing the sclerosant with air to create foam. The foam displaces the blood in the vein better than liquid sclerosant, leading to better contact with the vein walls. This technique works wonders on larger veins. You get more coverage with less sclerosant, which is a win-win for you and the patient. You can use a sclera in foam form, but keep in mind hypertonic saline isn't as commonly used because of its irritant properties. Ultrasound-guided sclerotherapy. This allows you to see the veins you're targeting, especially deeper veins that aren't visible on the surface. This reduces the risk of complication, gives you better control over where the sclerosant is going, particularly useful for larger veins and perforator veins. Again, a sclera is preferred because of their safety profile, but you can still use hypertonic saline with ultrasound guidance. Cryosclerotherapy is about cold therapy combined with sclerotherapy. Cryosclerotherapy involves freezing the treatment area before the sclerosant is injected. Early studies suggest this reduces the pain and improves outcome. But here's the thing, it's still new and more research needs to be done before we call it superior to traditional methods. Typically, a sclera is the sclerosant of choice here because its compatibility with the cold temperature. For best practice management, these are the recommendations that we recommend you take. Sclerotherapy is highly effective, but to get the best outcome, you need a solid foundation in venous anatomy, patient selection, and precise technique. Remember to go back and review the medical history, people that can be treated, and contraindications and warnings. Perform a thorough physical exam and use duplex ultrasound when necessary. You got to know exactly what you're working with. Informed consent. Your patient needs to understand the procedure, the risks, the benefits. This is where education is key. The technique involves using fine needles and selecting the correct sclerosant concentration. Post-procedure care is immensely important. Make sure your patients understand what needs to be done by giving them detailed post-care instructions and check in regularly. Incorporating sclerotherapy into your practice requires training and certification. You want to stay on top of the game. You want to attend workshops, get certified, and continue to get CME education. Facility requirement typically requires a clean, sterile environment with sterile needles, syringes, sclerosants, and compression stockings. These right tools will lead to the right outcomes. And for staff education, your staff needs to be prepared just as you are. Train them on patient prep, post-procedure care, and how to handle emergencies. The more they know, the smoother your practice will run. We highly recommend that you inject sclerotherapy into your staff if they need it. This will give them firsthand knowledge of what the patients will experience and what they need to tell patients when they leave. For marketing and patient outreach, you want to develop pamphlets or videos to educate your patients. Let them know what sclerotherapy can do for them. Social proof such as before and after photos, with permission obviously, and testimonials can help if you post these on social media to build trust with potential patients. Setting patient expectation is huge. Patients need to know what to expect. No false promises, no overselling. Set realistic expectations about the number of treatments, the results, and the time frame. Also, remember, they need to have long-term maintenance plans. As we said before, this isn't a one-and-done situation. New veins can form, and a maintenance treatment might be needed down the road. These are the legal and ethical issues in sclerotherapy. Confidentiality. Stick to HIPAA guidelines. Keep patient records safe and secure. Informed consent. Every procedure, every time, have to document everything. Advertising. Don't overpromise. Your advertising material needs to reflect the reality of sclerotherapy, not what you wish would happen every time. So we've covered a lot of ground today, from basic sclerotherapy to talking about advanced combination therapies and practice management. Remember, it's not just about treating veins, it's about building trust with your patient and staying on top of the latest research and running your practice with integrity and precision. Thank you very much for listening. This is Dr. J. Park with Sclerotherapy Training Online. If you have any questions or comments, please contact us. Thank you.